Hi, thanks for joining me. My name is Mike Brusca. I'm a partner at Davison Brusca. I focus my practice on long-term care, neglect, and abuse cases, and that includes the topic I want to discuss today, which is assisted living facilities. I want to talk about what they are, the basics on how they operate, and what are some of the dangers that come along with assisted living facilities. Now, assisted living facilities kind of fall into the middle of what we would call the continuum of care. So let's assume you have like a graph line. The most care that a person's going to get in long-term care is skilled nursing or nursing homes. They're also called subacute rehabs, but these facilities are regulated by the state, and they're also regulated by the federal government. And they have minimum staffing standards, they have minimal care standards, and they are the highest level of care on that continuum of care. So that's what you have on the one end. Now, let's go all the way to the other end. You have independent living. Independent living is where we would call it senior housing. The people require really no assistance, maybe light cleaning, things of that nature. There's usually some kind of transportation arrangement or a bus or van that'll take people to the shopping centers, pick up groceries, things of that nature. But they're more or less all independent, and that's independent living. Now, in the vast range between those two, that gap is filled with assisted living. So the level of care that can be expected in assisted living is very variable, and that's what I want to talk about. Now, unlike a nursing home where a person is almost always coming from a hospital before they go to the nursing home, assisted living facilities are going to be admitted, or those residents are going to be admitted from home. Now, generally speaking, what happens is a family identifies that mom or dad or their spouse has either cognitive or physical disabilities that make it such that it's not really safe for them to be home on their own. In particular, if they don't get out much 24 hours a day, they require some level of assistance, more than perhaps what you could provide with a home health aide. And so most people wind up contacting assisted living facility companies from home. And what will happen then is the assisted living facility will send a nurse to the home, and they will do an assessment, and then they will make a determination as to whether or not that person is a good fit for their facility. Upon admission, there's going to be a general health plan or health service plan and a general service plan. So these are basically plans of care that are going to delineate what they're going to do for that person, and if they have any specific health concerns, what they're going to do to address them. Now, most assisted living facilities also have variable levels of care. Usually there will be something like a level 1 care, level 2 care, level 3 care. Whatever that is, the top level of care is usually some kind of memory care or something along those lines, or a specialized unit that handles people that have either dementia or Alzheimer's. In theory, the idea is that the staff that work in that unit are going to be trained in cognitive impairment and can provide better care. Nursing homes, the aides are going to be certified nurse aides. Assisted living facilities can use certified nurse aides, but they generally don't have to. They will use a less qualified aide, a certified home health aide, which does not have the same training requirements and testing requirements as a certified nurse aide. And that's who's going to populate the facility. Additionally, it's usually staffed with licensed practical nurses as opposed to registered nurses, depending on the state regulations. And the idea is that this is an environment where a person can come in with certain deficiencies, but as long as they're safe to be there, they can stay there and what they call age in place. In New Jersey, where I practice, primarily the regulations say assisted living facilities can accept and keep up to nursing home level of care, provided they can deliver the care required. Okay. That's what assisted living facilities are generally. Now, here's where the problems arise. The problems generally arise when assisted living facilities accept people they shouldn't, or they keep people too long. So why would you do that? Well, unlike nursing homes whose primary payer sources are Medicaid, right, and Medicare, there are some private pay residents, but they're few and far between. In assisted living facilities, most residents, and by most, I mean 90%, are going to be private pay. That is, the family is paying directly. They're not inexpensive. These can be $5,000, $10,000, $15,000 a month, depending on the level of care required. Some states like New Jersey require assisted living to take some Medicaid residents, but it's a small percentage. I believe in my state, about 10% of their beds have to be Medicaid beds, but the other 90% can be private, or they want to be private pay because the payer source is much higher. And so there is this financial incentive not to let go of people they have or to say no on the front end. All right, here's where some of the problems arise. Number one, most ALFs or assisted living facilities require a doctor to sign off on suitability. Now, I will tell you straight away, the overwhelming majority, probably, of general practitioners do not understand the difference between assisted living and skilled nursing and are relying on the facility and their assessment more than their own judgment. Additionally, when I talked about the general health plan or the health services plan, when they develop those plans, they do not involve a resident's doctor. So if you have a person that's at high risk for falls, the doctor is generally not going to know what interventions they're putting in place to prevent falls. Now, the other thing with assisted living facilities is they don't generally deliver the care required of nursing homes, and they don't have the same interventions. In most places, the minimum staffing standards that apply to skilled nursing facilities do not apply to assisted living facilities. They just have to have a reasonable number of staff or sufficient staff to meet the needs of the residents without any kind of math formula. And so what you generally see is staffing based only on census or the number of people in the building. So we got X number of people, we got X number of certified home health aides, and 1 LPN per unit, and no RN in the building overnight. That's a typical pattern I've seen multiple times. That can be a problem because they're not generally staffing to how sick or the people are, how much help they need, only to numbers, right? And so that can be a significant problem when you have people that require a lot more supervision than they're going to get typically. Like I said, there are no federal regulations governing assisted living facilities, so the level of care they provide is not standard. If you're in a nursing home, the level of care in New Jersey is the same expectations as it would be in Pennsylvania, Oklahoma, Texas, Nebraska, or California. It's the same federal regulations that drive the care. Assisted living facilities, only state regulations. Additionally, with skilled nursing facilities, there's a lot of data they have to provide to Medicare, and then Medicare makes that public. With assisted facilities, there's very limited public information. Where you would see clear problems with a nursing home on the Medicare Care Compare website 1 to 5 star rating system, that is, if you see 1 star, that's bad. ALFs, you don't see that. And so you're not going to know how they're performing with any kind of objective data in most places. Additionally, in some places like New Jersey, they don't get surveyed by the Department of Health as frequently as nursing homes. And so these factors can cause these issues where you have a strong motive to hold on to somebody. And let's be clear, if someone goes into assisted living, they're not leaving, all right, especially if they're there for cognitive issues. Whether you have Alzheimer's or dementia, there are progressive illnesses. That is, they are going to get worse. It's not on a linear schedule or predictable timeline, but they're not going to improve. At some point in time, they're going to stop knowing various family members, and they're not going to know where they are, and it's just going to go trend down. The rate, you don't know, but that's what's going to happen. So at this point, the family is 100% reliant on the facility to say, number one, whether they're a good fit, and number two, what level of care should they be in. Now, let's talk about those memory care units. They can be problematic, and The folks that are going to go into memory care units, candidly, are no different than skilled nursing facility residents. I mean, you have people in nursing homes that are there solely for their cognitive impairment. When you look at these memory care units, they are nursing home residents. A lot of them have incontinence issues. They need help with activities of daily living. They may be wheelchair and bed bound. They are nursing home residents. Except in a nursing home, you're going to have minimum staffing standards, more regulations that are going to apply to the care delivered, and very clear expectations about what should happen. In an assisted living facility, you're not going to have that. So, like I said earlier, these are instances where a person should be discharged to skilled nursing because they can't get the level of care they need in an assisted living facility because the staff aren't trained as well. There's not as many of them, or certainly not requirements so that be as many. And there may be, long periods of time where there's no registered nurse even in the building. So that's where problems can arise. In assisted living facilities, I have had pressure injury cases where a person is bedbound and just not being moved. I've had many cases with falls and brain bleeds and falls and fractured hips that lead to death because there was no supervision. They just don't have enough people to supervise, which is what all those cases are about. It's just having enough people to have eyes on this resident to be sure that they're safe. And when you can't do that, bad things happen. Additionally, in assisted living, a lot of the interventions that they will use to prevent falls, they don't use in assisted living. So for example, position change alarms, which are alarms that sound when a person is at very high risk for falls and has cognitive impairment, doesn't remember to use the call bell light or pendant button to summon help when they need it, right? And so what happens is they get up, and if you have a position change alarm, it's going to notify the staff right away. This person is at high risk for falls and in danger right now. In my experience, many assisted living facilities do not use position change alarms. They also do not tell the families this. Even though they're commonplace in hospitals, they do not use them in assisted living frequently. Actually, beds in the low position is something that you will see as a standard intervention in nursing homes. I have seen in assisted living facilities where the person has their own bed. The problem with that is if they're in a low bed and they tumble out, they fall 18 inches versus if they're in their own bed and they fall out, they fall 2 to 3 feet, and that can be catastrophic. Additionally, in nursing homes, they're going to use crash mats when they have a person who does have that problem of rolling out of bed, which is a mat on the floor. So if they go out of bed, they hit the mat, and there's the damage is, maybe some bruising. Crash mats are generally not used in assisted living. So if that person is at that risk, that can be a very significant problem. So what to do? So if you're looking at assisted living facilities, you may want to ask about suitability versus nursing home. That would be my key questions. You may want to take the general care plan and general service plan to the pediatrician or the geriatrician and find out, like, what do you think about this? Is this enough? Do we have enough interventions in place? If your parent gets up and wanders without using their cane or their walker, or is inclined not to use a wheelchair or ask for help when they're told to because of cognitive impairment, understanding, well, how do you plan to address that? If you have a parent that's moving from the general unit into a memory care unit, asking questions, is this a better unit than a skilled nursing facility? I understand that when you have people with cognitive impairment, moving them from one place to another can be traumatic and difficult. So but if you're already going to move them from one unit in the building to the other, there's no difference. Whatever that transition trauma is going to be, it's going to be. Whether you move them into a memory care unit or you move them into a different facility, they're still going to experience those same issues. And so understanding, how is this unit enough, or how does this stack up against a nursing home, or what is really the best environment for my mom or my dad? And asking those questions. It is important to advocate because I find that most families feel tremendous guilt because they trusted the facility to make the best decisions in these instances. And keep in mind, whether they're aware of it or not, to go to a family and say, listen, our facility is really not the best place for you. They should go to another facility. That administrator is looking at a significant financial loss if they do that. The last thing I want to talk about are what are called managed risk agreements, and you'll see this in most jurisdictions. Managed risk agreements are where there is a significant safety issue, and the facility wants to make the family aware of it, that they can't prevent sometimes problems that may occur from that. So, for example, a classic one is smoking. Dad smokes, and the facility's like, look, we don't want them to smoke, but they insist on doing it. So what is laid out is a managed risk agreement, and it's a document that the administration or the wellness nurse is going to go through with the family and explain the risks. If he's going to stay here and do this, these are the risks involved. I would tell you, if the facility wants to do a managed risk agreement with you, you should pay careful attention to that. And at that point in time, it may be a signal to you that this is not the best level of care they can get. Now, look, families may decide, I'm willing to take that risk because dad has friends here, he loves the staff, whatever it may be. But that's a personal decision for the family to make. And in this instance, the facility has made it clear, and it's very fair to them, understanding that we are not a nursing home and we can only provide a certain amount of interventions and level of care regarding that particular risk, which I think is the appropriate thing to do. I can tell you that I have had many assisted living facility cases over the years, and I have seen very, very few managed risk agreements. So that's what I have to say about assisted living facilities. If you're in that position of choosing, I hope this has been helpful information to you, and good luck in advocating for your loved one. Thanks for listening.